I am now pleased to introduce our first speakers, Clese Erikson and Randl Dent. Clese and Randl work at the Fitzhugh-Mullen Institute for Health Workforce Equity at the George Washington University. We're so honored to have them with us today. Clese and Randl.
Thank you for the opportunity to present today. I was really excited to be invited to be a part of this panel and talk about behavioral health workforce shortages. This is a topic that's near and dear to so many hearts as we're just coming out of a major trauma nationally with the pandemic and all of the other behavioral health workforce crises that we're facing in terms of, what we've learned about health disparities and racial inequities. And that was on top of an existing undersupply of behavioral health services prior to the pandemic. So we are hoping that we can share some of the data that we've put together with you, which was put together in part funded by SAMHSA, it's a grant that we got to build a unique database on the behavioral health workforce. The next slide. They provided us with $3 million of funding over 3 years to develop a database. And of course, all the findings that we're going to present today, including some of the work from Randl, does not necessarily reflect SAMHSA or HHS, but is, I think, an important set of information to make available to you today. Next slide. When we released the data that we put together, we also had a companion blog post that go out in Health Affairs pointing out that the data that we put together paints a pretty stark picture. We had a shortage of providers in the past, and now we're able to put together a unique database that really shows down to the county level the supply of providers across the nation. But it shows some serious gaps, as I'll present in just a moment. Next slide. I want to spend just a minute on how we built this database, because this was not something sitting around that we just took advantage of that had already put this information together. We had to spend a lot of work. It was a labor of love and a creative experience to use prescription data to identify the prescribers of behavioral health medications, psychotropics, and medications for opioid use disorder. And through that, we're able to identify not only specialists, psychiatric and addiction medicine specialists that are prescribing these medications, but also the primary care physicians, NPs and PAs, and other specialists, including emergency medicine physicians and OBGYNs, among others, that prescribe a significant amount of behavioral health medications in our country. Separately, we compiled state licensure data for the following professions here: psychologists, clinical social workers, professional counselors, and marriage and family therapists, by contacting all 50 states and all of their licensure boards. And I want to send a special shout out to those that make their data available on the website for us to download, and particularly if they include information like data on race ethnicity, which Tennessee does, or other information about provider demographics. So we pulled this data together, next slide, and we're able to identify one point. And I want to point out that this is really important, because when we released the Health Affairs blog post, we got a lot of media attention about this. And one of the quotable quotes that came out of that was that this data just didn't exist before. It's really kind of shocking to think that despite all the behavioral health needs, we didn't have data on our workforce, particularly for counselors and therapists. Next slide. So now it does exist, and we found that there are 1.3 million individual providers that we can identify and map down to the location, including almost 700,000 behavioral health specialists. That includes psychiatric and addiction specialists, psychologists, and counselors and therapists. And then, as I mentioned earlier, we can also bring into visibility the primary care physicians and advanced practice providers, which are almost 450,000 in total, who are a big part of this workforce, and in fact prescribe twice as many, or half of the behavioral health medications that collectively in the country compared to psychiatric and addiction medicine specialists. Next slide. But we can do so much more with this data and be able to go down to the county level, as I'm about to display on the map. We go live, which is always a little risky when you're pulling these things up online. But you can see my screen here. shows a map of the United States, and what we're looking at right now is psychiatric and addiction medicine specialists. And you'll note that there are a lot of counties that are shown in white here, and that's because they don't have any behavioral, psychiatric, or addiction medicine specialists. That's half the counties in the US. But as I mentioned before, we can show primary care providers and how they help fill in gaps, as well as advanced practice providers. And you can see the ratios change over time. And you're able to mouse over any county and see the number of providers. And in this case, I'm going to go to Harris County, where I went to high school. And this is Houston. And you can see there are about 5,133 prescribers of behavioral health medications in Harris County. And that number is going to change over time as we go through the tool a little bit. So if you just focus on those that accept Medicaid and now go to Harris County, you see it's now the number has dropped to 3,500. We can also, because of the database that we've developed, show those that are prescribing serious mental illness. And then again, you go to Harris County and the number drops now to 1,648. So anyone can go on this tool. I believe a link has been posted in the chat for you, and you can click and access the data and find out how the supply of providers varies in your county or state. But it's also data that we've put together, and I'm going to get rid of all the providers now and start showing what psychologists, and you'll see that we get the same sort of distribution for psychologists as we do for psychiatrists. There are a lot of counties that don't have any psychologists, but when you add in counselors and therapists, you get a different picture. But still, there are counties that don't have any providers available. And you can go into this tool and see how things change for, I'm going to get rid of psychologists again, and show that there's a variety of providers. You look and see that California's got a pretty robust supply of providers when you look in the whole, and that's because they have a lot of marriage and family therapists. But when you look at their licensed professional counselor supply, that changes, and they in Nevada really have very few. And this, I think, is an important part of understanding the workforce, because at a time when we need all hands on deck to treat our behavioral health workforce crisis, we need to, states have a lot of room to be able to cover and reimburse for Medicaid, through Medicaid, for example, whether they cover licensed professional counselors or marriage and family therapists. And half the states don't reimburse for those services. And that's a missed opportunity to bring into full play the possible workforce for you. And when we talk with providers, employers of behavioral health providers, licensed clinical social workers and professional counselors are the ones that are most in demand and the hardest to recruit. They're now offering retention bonuses and recruitment bonuses. And the retention bonuses in particular were not something that were available, but also increasing salaries to be more competitive with telehealth opportunities that also don't have as much paperwork. And we also need to think about scope of practice limitations too, because in half the states, they don't have lots of these counseling and therapist professions are sometimes not able to diagnose for services, or they're limited in what's billed in Medicaid. So there's a lot of flexibility that could be introduced to increase the supply of providers through policy changes of that nature. So now I'm going to, and that one last point I wanted to make when we go back to psychiatrists and not psychologists and primary care providers and where they're coming into play is that you can see in states, in areas where counties where maybe there's more primary care providers that are offering service, that you can offer Project Echo type models to support those primary care providers and make sure that they are connected to experts that can make them more comfortable and experienced in training. And then in areas where you don't have any providers at all, you can bring in and focus more on building up broadband services and telehealth access in those communities to make sure they have access to the workforce that they need. So I'm going to come back to the slide deck now and talk a little bit about our findings around peer support workforce. Because while the data that I presented to you is a major leap forward, it is missing data on peer support providers, community health workers, and others. So we not only need to continue to maintain data like I just showed you, but invest in building the data on these vital members of the team as well. Through other means, through our SAMHSA grant, we're able to use job postings and change in demand for peer support job postings over time to document a 17-fold increase in demand for peer support providers. And we were able to do analysis on this to look at what might be behind those, the growth. And we had hypothesized, next slide, that the demand would be associated with Medicaid reimbursement for peer support providers. But in fact, we found the opposite, that it was not, although Medicaid expansion was. And so states have a lot of room to be able to improve, next slide showing up, to be able to increase their use of peer support providers, potentially through greater reimbursement from Medicaid beneficiaries and peer support. We found that only 206,000 beneficiaries in 2019, the same time as periods we did this analysis, were had services paid for by Medicaid. And that's after 43 states have gone through this state plan amendment process and other methods to be able to enable peer support services to be billed to Medicaid. It's just not being taken up to the extent that we would want. So that's another opportunity for states to increase the workforce, because this workforce with the lived experience is an important avenue for helping people with serious mental illness and substance use disorder address their needs. Next slide. And this is my last slide before I turn it over to Randl to take on some more. But the point I want to make here is that we need to continue to invest in data and liberate it. No one needs to likes to talk that much about data, but it can be so valuable for documenting gaps in care and services and really informing our understanding of our workforce. And this is data from the state of Tennessee on counselors and therapists. And on the left-hand side, you can see that the variation in supply of providers, the same data I showed before, at the county level for 2021. And then on the right, it's the same map, but now counties where there are no Black counselors or therapists have been grayed out. And you can see that's over half the counties in the state of Tennessee. And when you take into account the recent study that the AMC put together along with HRSA that showed that counties that had more, a higher ratio of Black physicians had greater life expectancy for the Black population area. And also, if we could do more work and have data like this available to do research, we could probably show the same thing for counselors and therapists. So, but in the meantime, I'm going to turn it over to Randl, who's going to really go into great detail about some of the studies that we've undertaken.
Thanks, Clese. So I'd like to spend a little bit of time talking about the redlining study that we conducted with our team. And so it's really just one example of the questions that we can ask with the database that our team has built. For those of you who are not familiar, redlining was the practice of categorizing wealthier neighborhoods with predominantly white populations as low financial risk, and that was color-coded with green, while designating neighborhoods with Black and immigrant populations as high financial risk, with the highest financial risk being color-coded as red. Previous research has found that residents living in formerly redlined areas were at a higher risk for later cancer diagnosis, higher risk of preterm birth and other birth outcomes. And relevant to the current study, poor mental health. When we saw that there was some evidence that residents in formerly redlined areas had poor mental health, we wondered if there were behavioral health workers in those areas that would be able to meet those needs. Next slide, please. To answer that question, we examined two cities, Richmond, Virginia, and Greensboro, North Carolina, to understand how behavioral health providers were distributed across different areas of both cities. When we compared these green HOLC areas, and as a reminder, those were categorized as the lowest risk, to the redline areas, highest financial risk in both cities, we found that redline areas were associated with lower per 1,000 population counts of psychologists, counselors, and therapists. Those redline areas also had a current day higher percentage of Black residents and higher area deprivation scores. When we looked at psychiatrists in Greensboro, we also found that redline areas had lower counts of psychiatric specialists. But when we looked at that same analysis in Richmond, we saw that redline areas did not have significantly different psychiatric specialists counts per 1,000. And so the QR code that's on this slide links to our paper that was published last year. Next slide, please. So these findings suggest that these historical policies like redlining that are embedded with racism are still associated with present day access to care and health outcomes. These findings are consistent with recent research that redlining has led to increased racial segregation and continued disinvestment, and is associated with health inequities. We would really like to expand this analysis to see if these findings remain true for other formerly redlined cities. Next slide, please. So now I would like to talk a little bit about strengthening pathways to the behavioral health workforce. And Karina, you can go to the next slide. In some of our recent work that's not yet published, but we hope to publish soon, we found that Black women are actually pretty well represented in both the student population and the workforce for counseling, marriage and family therapists, and social work professions. We also found that Black women were underrepresented in the psychology and school psychology workforce, and with the stats that Catherine shared earlier, that I'm sure comes as a surprise to no one. When we examined the student population, we did see that there were many Black women students in the pathway to becoming behavioral health professionals, and so we do expect an increase in the behavioral health workforce. You'll see in the bottom left quadrant, similar to other professions, we found that Black men were underrepresented for all professions in both the workforce and the student population. And so what I would like to say lastly on this slide is most of the current national diversity statistics focus on the psychologist workforce or the psychiatrist workforce, but we know that's only a portion of all behavioral health professions. A few caveats about this work. The workforce data that we share is based on self-reported occupation from the American Community Survey. So we cannot confirm whether respondents are actively licensed or practicing clinically. To understand that, we really do need a publicly available database, just like Clese was saying, of behavioral health providers and their racial and other demographic measures that are important. There are some databases that exist like this for the physicians, including the American Medical Association master file. And so they're able to know a lot better about the number of providers, where they are located, and what are the racial and demographic characteristics of their provider population. Next slide, please. So one way that we've been talking about at our institute and in some of our work to strengthen the pathway to the behavioral health professions is to leverage the talent that exists within communities. We think that we can do this particularly by engaging community college students. The community college student population is racially and ethnically diverse, and community college students may have a greater interest in returning to their home communities to practice after finishing health professions training. Next slide, please. So we've seen that medical schools have found some success with partnering with communities to increase the diversity of their student population and train locally invested health professionals. The QR code on this page links to a paper that I recently co-authored with some colleagues at UC Davis regarding revolutionizing admissions practices to recruit and train a more diverse workforce. And so this paper talks about practices that health professions institutions are currently putting into place, and something that you might want to try at your institution too. In regard to policy levels strategies, we really do need more federal dollars that are going to training behavioral health professionals in the US. One specific way that we could do that would be to continue to expand the Minority Fellowship Program by SAMHSA. It currently funds about 200 fellows, but imagine if it was funding a lot more. I also would like to note that loan forgiveness and repayment would go a long way in helping the future and current workforce of mental and behavioral health professionals. Next slide, please. Now to wrap up, I'd like to talk a little bit about supporting the current behavioral health workforce. Next slide. So these are just a few headlines from pretty much the last 6 months. So you're seeing a shortage of mental health care professionals in Texas, you're seeing a similar thing in California, and that hiring alone isn't going to solve the healthcare worker shortage, especially for behavioral health workers. It's also important to note that certain populations, including therapists that identify as Black, Indigenous, and people of color, are inequitably, these things are inequitably experienced by providers from those groups. Next slide, please. So how can we begin to tackle what is a very huge and complex issue? I think the first thing that organizations can do is listen to the concerns and needs of behavioral health workers and co-design strategies to alleviate the factors that are causing worker stress. Many times administrators don't really understand what life is like on the front lines or how certain operational decisions will affect day-to-day clinical practice. Providing opportunities for behavioral health professionals to voice their needs and concerns without fear is crucial to being able to address the issue of burnout. Last fall, SAMHSA released a resource that's QR coded on this slide about what organizations can do to address burnout among their behavioral health workers. For individuals, we've seen a lot of behavioral health workers building coalitions because they've learned that there's a lot of strength in numbers. And so we've seen a huge uptick in health workers organizing, not just in the behavioral health professions, but among other health professions as well, including physicians. Recently, mental health clinicians at Kaiser Permanente facilities in Northern California were able to negotiate a deal where they got additional hours to perform indirect patient care. So that might include patient calls and emails, tailoring treatment plans, or making referrals to social service agency. They were also able to negotiate more therapists in the labor management committee so that they have more of a say in the decisions that are made at their organization. It's also important to note that mental health professionals are helping people cope with some of the most stressful moments of their lives, and we know that that takes a toll. So it's important to employ some of the strategies that mental health professionals teach others, and that organizations provide time and space to do just that. On this point, I particularly think about mental health professionals who are just entering the field and may not know how best to take care of themselves while caring for others. In terms of different policy strategies, we know that reimbursement rates are an issue and that they're unequal between physical healthcare and mental health care. And lastly, on this slide, I would really like to just talk about reducing barriers to practicing across state lines. And so I live in the DC, Maryland, Virginia area. I live in Virginia, I work in DC, and that's the case for many in different areas around here. But now that psychologists in DC, Maryland, and Virginia are all part of SIPAC, they're able to apply to practice across state lines. And so it opens up my choice of provider in this area. And the last thing I would like to note is that there's a similar compact coming starting for counseling in 2024. Next slide, please. And so we would just like to thank you all for your time, and Clese and I have put our contact information on this slide and links to the trackers, and there's also one in the chat, and I'm happy to pass it on to the next presenter.
Thank you so much, Randl and Clese, for giving us that overview of the tracker and sharing a lot of important resources and strategies to improve diversity in the workforce.